This is actually a syringe, 1 cc, and it's actually divided in 100 bits, believe it or not. And you can see that, and you can see on the one side they got the whole minim thing going on. Remember minims? Yeah, but I haven't had to give medicine minims. And the other side is tenths of a cc. But if I wanted to give 0.44, meaning 44 hundredths, I would have the ability to do that because in between each part, it's actually divided into 10, believe it or not. So I have my tenth, all right? I put my needle down in my vial. You try not to touch the liquid, to be honest with you, because you don't want to do something to contaminate the liquid, particularly if this was, I am bleeding. Anyway, if this was a multi-dose vial. No, but don't touch me. All right, so anyway, I'm going to push my air in. I turn my vial upside down, all right, and now I aspirate the amount of liquid that I need. Okay, mine has a gigantic air bubble. So that's how I'm going to do that. Sometimes that's really not enough to do it, and you have to like take out your pencil and whack it. I will tell you that a 27, 29, 31 gauge needle is so flimsy that if you whack it, you might come out with a needle bend. So that's why I'm sort of hanging on to it like this. All right, but I don't want to have any fluid, air bubbles displacing my medicine. And one problem with School of Nursing is it's all of these, because it's old, all of these Saccharina, I'm going to make sure it's still on the hub. Okay, so here is my 10th, all right? Now I come back over, and I'm going to my medicine sheet. Was I supposed to give 1/10 of this, and da-da-da-da-da, patient's not allergic, this, that, and the other. Get in the habit of not capping needles, all right? Because we had a fair few of patients today who had hepatitis. Did you notice that? But they weren't on isolation, right? But they did. Other patients didn't have a label like that, but may have actually gotten a transfusion from someone else. So not only they have their blood in it, and everyone they commingled with, but all those blood comminglers, and it just gets exponential how much pathogens you're potentially being exposed to. So what I do is I don't want to have to remember when I can and cap a needle. So I usually just put one hand behind my back and scoop up the top like this. Yes, I say. And you can just find something to do that. All right, so now I'm not going to have the chance. You can't put this in your pocket because you may actually poke yourself. Does that make sense? And so on. And so sometimes actually they provide little trays or a basin. You can carry it down there with you and so on. When I get to and I take this with me, remember they said to label things? If there was going to be some big honking delay between when I pulled this up and when I was going to give it, this is the thing where you could put something and label it here. Actually, sometimes, usually the vials aren't that gigantic. I actually just tape it on there. Does that make sense? So that, because otherwise I might end up with a cassette with three syringes with clear liquid and not remember who's what. All right, so I go down, I do the patient room. Hi, how are you? Can you tell me your last name? And I always ask them, do you have any allergies you can tell me about? Because that human error, that MAR could be wrong. All right, and so then I go, great, I'm here to give you your TB test and so on. Show me your arm. I'm checking their armband with the visit number on there and so on. And so now I'm up to the point, can I borrow your arm? I'm actually going to give the shot and so on. Yeah, really, can I borrow your arm? So I do wear gloves when I give shots because if you poke somebody with a sharp object, frequently they bleed, okay? And then I don't want all those people's blood on my hand or even microscopically under my fingernails. You don't have to pull meds, have this on to pull up these meds, but when you get to the patient area. We saw somebody give a shot today without gloves. And I just don't recommend that. I just think that is, and the CDC does not recommend that. And your boss, because you're required to wear gloves when you're giving shots, could actually, write you up and get rid of you if you were out there doing that a lot. We have to see it. So I pick where I'm going to give it. Surgical scrub, round in a circle. Currently it's isopropyl alcohol that we use for this. I've seen chlorhexidine. They may switch to betadine. Depends on what the Center for Disease Control says. I do my shot. I look for my bevel, and it's just a little, so I'm going to do it up so you can see it's a little tiny gesture like this, right? In shots that are deeper, you do actually aspirate because you so want to make sure you're not accidentally in a blood vessel. And if blood pulled up in there, you'd be like, oh, we won't be doing this right now. Click and throw it in here. Does that make sense? And go pull up a new medicine and so on and so forth. But this one, I'm just in the skin. See, I'm about really low parallel to the skin. I'm not even in very far. I don't have to go all the way up to the hub. I just have to get that bevel in. You could be just like this. All right, and then I inject the medicine, all right, and then I'm out, and I throw it away. Every, excuse me, bedside has those sharp containers, those point of use. And we had that nurse telling us today that patients, she's had experiences with patients trying to take the IV tubing home and all kinds of stuff. There are people out there who obviously have drug use issues, but we don't want them using used stuff, all that kind of stuff. So we want to make sure everything gets in a sharp container. And now I would then write on, I would have to chart somewhere on this that I'd given this medicine, and it's their left forearm, so everybody else knows where to look at. So I'd like you to, and I'm going to give you something different. I would like you to give your arm 0.3 mils of normal saline. Now I have the option of either being at a 45-degree angle, you with me? At a 45-degree angle, or if I had a super, if I had a person who had well over an inch of fat on their body, I could actually make the decision to be 90 degrees because there's no chance in me below the fat into the muscle. Some of the folks we saw today were pretty skinny and pretty tiny and pretty emaciated. And some people, I actually have to pinch their skin up with their fat off their muscle, do you know what I mean? To make sure that even doing it at the 45, that I wouldn't get below there, because they have such a thin layer of fat. They're so emaciated that I'd get into their muscle, all right? Nobody wants you to push a needle into them, you know, like, and this is one of the things, you know, I tell the faculty faculty teaching subsequent courses call and complain to me about everything that ever got taught in fundamentals. It's always my fault. So she had a whole litany of stuff that was my fault. One of the things that is her big pet peeve, the future faculty, is that students come along and they're pushing needles into people, and nobody likes that, all right? What the public wants and what you want is for you to throw a needle in. They want you to throw it in like a dart, all right? Inject the medicine slowly and get out fast, all right? Because nobody wants you to go, you know, all that kind of stuff. And you're afraid to hurt people, and it's a different feeling anyway and stuff like that. And students do tend to be a little slow with it. So, but you want to get in, all right? You could decide to aspirate, to pull back to see if you're in a blood vessel. There's a very low likelihood of that. So most people don't aspirate and check for blood with a sub-Q. So it's get in fast, you know, most slow injection, because sometimes it stings, all right? And then, so I'm putting it in, this is my version of slow, and then out in a hurry, and get rid of my medicine. Okay, so intradermal, bevel up. This one, I usually do the bevel up too. I'm not sure that it does matter in your text. 45 degree is intradermal. It's, sub-Q, different locations, all right? And more about the medicine that you give yourself. All right, so go ahead. Oh, do they have any allergies? What is this medicine? When is it due? So on, oh, here's the medicine. Is this the concentration? Do the math if I need to do it, right? Because there were, you know, it might be that it's 101 mil and I'm only supposed to give 50, so I do my whole, 50 over 100 times 1, I'm going to give a half a cc. Does that make sense? Take my thing, swab it off. I'm only going to give a half a cc. All right, so I'm checking it out. Put my air in, do all this. This is, if this was a narcotic or something, not insulin, not heparin, I would not need to be checking it with someone else. I would then do my final check. Is this, is this that, and that's whatever. Sorry. Go into the, sorry, I'm not gonna. All right. So I'm carrying it in there, I go into the thing, take the patient, say your last name, do you have any allergies, read the armband, my last check. All right, how are you? Doctor's ordered that you're gonna have a flu shot before you leave, a pneumococcal flu shot and so on. Pull up their sleeve, you know what I mean? Feel for their chromium process, I feel the bone, 2 fingers down, here's the location, use my swab. All right, and I like to give people something to do. Because does it hurt to get a shot?
Yeah.
Yeah. All right, and so you're not making friends. So say, okay, on count 3, I'm gonna take a big deep breath for me. I'm pinching off their skin. All right, 1, 2, 3, boom. All right, this one we must aspirate to make sure we're not in a blood vessel. Notice how I didn't go all the way in, all that kind of stuff. I didn't need to do that. I just went in until I was thinking I'm in the muscle on my particular patient. All right, so now and that's why you can't have your finger over here, because you might start pushing it before you've aspirated. So I'm darting, right? I'm boom. All right, and I hold it with my other hand, and I'm like checking for blood. What would I do if I found blood?
Discard it.
I'd be like, oh, okay, and boom, and so on, and do you see what I mean? And I'm holding on this because this is bleeding. I got my gloves on, right? Okay, let's say boom, aspirate, nothing. Inject slowly because that's what the public wants. That's what you want, so I'm just giving it slow. Sometimes I just hold this off to the side. Okay, I get in, I get out fast. And you can, it's down in the muscle, and so usually you can rub to make it feel more comfortable and throw this away. And now what's my documentation? 1 cc, yeah. Yeah, so I'm going to say, and this is in my left deltoid, and it's usually DLT, literally L with a little circle around, or R, DLT. And I think at Huntington, when you give a shot, it'll pull up like one of those little drop-down menus where you can like click the one that you gave. Does that make sense? And we'll say that I gave it and so on, because we need to document the site. Because we may be giving a medicine in which they have to rotate the site, and also we want to be now checking and seeing if they had any medication. What if I put the needle in and the patient goes, oh my God, nurse, I felt that all the way down in my fingers. Take it out in a hurry, all right. We're going to have to prepare the medicine, give it in a different location, and we'd probably have to document that and send it in as an incident report, because they'd have to monitor that person to make sure they would have that. All right, so I would recommend that I think that in your book it actually allows you to give more. I take my chart and fill it out directly from Potter and Perry when John gives the lecture, and so they may actually allow you to give more in a deltoid muscle, but all of the complications with shots, that's where they are, right there in the deltoid. Okay, can you please give your human, let's have them give you, please give them 1 ml of your, right, and so on. I've got my gloves on, I've got the medicine, I've done the 3 checks and all that kind of stuff. Now, it's handy that she actually has a pillow in her arm to say to me deltoid, right? But what I do is fill in the acromion process, 2 fingers down right here. I could swab it like this. I'd say, okay. And she's not a huge fat person, so I'd probably pinch it up and say, all right, you're not going to feel a thing, right? Or you are going to feel a thing. 1, 2, 3. Take a big deep breath. Whack. Aspirate. Yeah, ow. Slowly. All right. Out. Sharps. All right. I could put a Band-Aid on this. And now I'm watching for the complications of the medicine. You know what, Mrs. Newman? You've had quite a few shots on that side, and so now I'm going to lift you towards me a little bit. I'm going to roll you over to your right side. Can you hang on to the rail for me? Yes. Okay, groovy. All right, so she's hanging on to the rail and so on. So I could hand on her acromion process. I could be feeling, they're trying to mimic, see how they're trying to show you the pelvic crest here and so on. This is ventral gluteal, all right? She doesn't even have a dorsalis. Does that make sense? A dorsal gluteal. She just has ventral gluteal, so I could be whack, aspirate, shh, out, hold this, whack, put this away. All right, so I could do that. Sorry, your stomach got dislocated. I hate it when that happens. And you're missing your crotch. This is terrible. Okay, so hand on my acromion process, her leg is rotated out, okay? Hand it like this or hand like that, or do this is the other way you could do it. And right here, boom, aspirate, slow, all right, pull it out. Let's try to see if you can get a partner and come over.